welcome to yet another episode on Knowing Your Medical Maestro. Today we have a special guest, Dr. Jackline Odhiambo. Jackie, welcome to the set of Knowing Your Medical Maestro. Kindly tell us about yourself.
Okay, you've heard my name is Jackline. I'm a consultant physician with a big passion for diabetes, and I'm stationed in Nairobi, and I have worked for many years. Yeah. I think that's the basics. The basics. I'm a lady of few words. Yes.
Yeah. Maybe you can tell us more for the layman what it means to be a physician. What does that mean? Because I think we know there's
Clinical officers, medical officers, and now physicians. Yeah.
Strangely, physicians are the people that people see the most, but most people don't know us by that name. So basically, to be a physician, you go to school and do your undergraduate. Then after that, you go back to school and you do your postgraduate in internal medicine. And then now you become a consultant physician. And then after that, now you'll go and do your subspecialty like cardiology, gastroenterology, diabetes. So those people, those are actually physicians who have subspecialized in something else. So to sum it up, I usually tell my patients, a physician is someone who sees a patient who is an adult and who does not need surgery. As long as you're an adult, you don't need surgery, we are probably the person you're going to come to.
Okay. So would it be the same thing as a clinical officer? Because we also know clinical officers see adult patients in clinic. So what would be the major difference between that and a physician as well? Especially clinical officers see patients in county hospitals. Okay.
The main difference between doctors and clinical officers is the schooling. Okay. Yeah, for us, we go to university to become first a medical doctor, and then now you go and specialize in your postgraduate, then you subspecialize further. For a clinical officer, they go to a medical college. And then after the medical college, they can still subspecialize. And yes, they still see patients, but theirs is not a degree, it's mainly a diploma course. So that is the major difference between us. We stay in school longer and we are able to do more than them, but they are still able to see patients and manage patients. Okay. Yes.
All right, that's very interesting. At least for our audience, they'll be able to tell the difference, because we know that that's one of the things and that people don't really understand between a physician and a clinical officer. So maybe you can tell us your journey, like why did you want to be a physician, or what inspired you to be a physician?
Okay, so there was this program when I was growing up, and by the time I say it, you'll be able to guess my age. When we were growing up, it was called ER. Yeah, and there was this specific guy, the way they used to go, I think it's our version of, for those guys who grew up later, House, but now the older version.
The 902 ER.
Yes, exactly. Yes. So how he used to come, very complicated patients, and he figures them out and he manages them and they go home happy. And that always impressed me, because you'd see something comes, it's like a puzzle that you figure it out and it's able to look very well. And then also I have uncles who are doctors, so also just seeing them, how they behave and how they do their work. So it's something I was exposed to since I was a child, and something I was always interested in. Yes. So that's where the seed was planted, so to say.
That's a long time.
That's a very long time ago.
So maybe as a follow-up question, you said that you are a physician with a keen interest in diabetes.
Yes.
So why specifically diabetes?
So specifically diabetes, because sugar and blood sugar management is something that has always been of interest to me. And mainly because diabetes is something that affects the whole body. Yeah, we say TB affects everything but your nails and your hair. Yeah, now diabetes will affect everything, including your nails and your hair. So when you manage diabetes, it's like you're managing the whole body. So for me, because it was hard to decide which area I wanted to subspecialize in. Diabetes is good because then I was able to specialize in every area. Does not mean I'm a nephrologist, a kidney doctor, or a cardiologist. I'm not any of those, but I'm able to see when there are changes in that part of the body and then refer the patients appropriately. Yeah, so that holistic nature of diabetes is what initially attracted me to it. Yes.
That's nice. So being a diabetes doctor, would you say there are challenges that you faced in clinic or even in your journey to being to managing a patient with diabetes? What would you say is one of those key things that actually made you now to really push forward into now wanting to learn more about diabetes and the journey?
When it comes to challenges, life is full of challenges. You cannot escape challenges, and the challenges just depend on the person. I think for me, the main challenges, well, there's always the schooling, because some of these things you can do your undergraduate in here in Nairobi, you can do your postgraduate here, but when it comes to the subspecialties, and especially during my time, you could not do it here. It's something that you had to do outside the country, either online or you go outside the country. So that, depending on your finances, can sometimes be a challenge, that opportunity to do that. And then also the time. You know, as you grow older and you're in school, you still have to work. So it's very hard to do school and work at the same time, because as you grow older, you don't have the luxury of always having someone pay for you school as you work. So again, combining school and work can also be a challenge, but it's something that is not forever, something that ends. And then also that thing of people always look at you, because sometimes you know how you grow up with some people and they always see you as that little girl. So even as an adult and you're trying to do adult things, and people still see in their minds like you're still that small girl. So convincing people that now you're a grown-up who is able and confident and able to manage things. Those are some, I think, of the main challenges. Yeah.
Are those the same challenges that you would say you would face even managing a patient, or even like, you know, the way you're a young doctor, you're just being diabetes? Are they some of the things that you find that if you meet a patient and you're managing a patient with diabetes, is it something that, do they have confidence in you now that at least they see you as young, or you would say those are some of just like it's a passersby thing, like you don't face them?
I think that's a challenge that most people see. Well, I'm not young anymore, but at that point in time, you get especially some older patients, or sometimes patients your age, and sometimes you even get patients who are younger than you, and they look at you and they ask you, are you old enough? You don't look like you're old enough to be a doctor, or you're old enough to be a consultant. But what I've learned with that is the first impression. But what you do is you just do your work. You talk to them and you manage them, and as they see your work, then they get to have that confidence with you. So it's mainly, if people view you like that, the main thing is just do your work. You just do you, and then the other people will come and see and follow.
That's nice.
Speaking of the, meeting the patients and your work, maybe you can take us through a typical day in the life of being a physician. Like on a normal working day, how does that look for you?
Okay, so on a normal working day, you would wake up. So for me, I'm stationed in one specific place. So you wake up, of course, you do your daily routine in the morning. So for me, I like to do a bit of working out in the morning. Then you have breakfast, you go to work. So if you have patients in the ward, you go and see the patients in the ward, which would usually take 1, 2, or 3 hours, depending on how many patients you have. And then after that, you go to the clinic. So for a physician, most of our days are spent in the clinic seeing patients. And the clinic can be as long or as short as how many patients you have or how complex the patients are. There are days you could have a clinic with many patients and you finish quickly because the patients are straightforward. There are days when you could have 2 or 3 patients, but you're there for a longer time because with patients you have to take time, talk to them, find out their fears, find out what they have, explain to them. So a day is never fully predictable, but that would be the basic outline of a day. Yes. Yeah.
That is good to know. At least you get to understand sometimes why when you're in the waiting area, you can wait for an hour when one patient has just walked into the clinic, and other times it's actually faster.
Yeah.
So at least we get to know what goes on behind the scenes.
Because the important thing is not to hurry a patient. By the time a patient is coming to you, they have spent time, they have waited for that consultation, they have thought about the things they want to say. So you need to let the patients talk. Talk and express themselves and tell you what they have before now you start your own. And then it's not like before where you'd tell a patient, here, take this and go. These days, you have to tell the patient you have this condition, then you have to explain to them their choices and the pros and cons, and then together you come to a decision. So especially that first visit can usually take some time.
So can you, just a follow-up question on maybe seeing a patient and how your clinic day works out. Would you say, like, what would you tell a patient before they come and see you, like, especially if it's a first-time patient? As in, what would you want them to know before coming to see you? Especially, and expectations as well. Like, what would that be?
What we would like to know from the patient, for one, no detail is too small. Because there are patients who come and they think this may not be relevant. Any details you have, give us everything. Let us decide what is important and what is not important. Because some things that you may think is not important may actually turn to be the most important thing. Then the other thing I'd tell a patient, if you're on any medications, it's always good to know the names of your medications. If you find that is hard, you can take a photo of your medications or carry the packet of your medications. And if they're seeing you for a first time and it's something you've had for a while and you've done tests before, you've been anywhere, carry. So basically come with all the information you have. Just bring it all and then let us sort it out and see what is relevant and what may not be so relevant. Yeah. And just become ready to take some time. Yeah, first visits usually take a while.
It's longer because also it's trying to also understand a patient from where they were managed. Then now you pick up and then now you manage them better. Exactly. Okay, that's interesting.
I think another question that would lead up to maybe the patients once they come in. For example, a patient gets to your clinic and they get the diagnosis that they have diabetes specifically. So what does it look like after, once you've been diagnosed and you have this condition? What are the steps that come after that also? Yeah.
So the steps vary depending on the patient. First, there's the diagnosis. For some people, they expected it. Some, they already knew it. Some, and people take news differently. Some people, they just take it in their stride and ask you, what should we do? Then there are also those people who, for them, they are not prepared for that diagnosis. So for them, it's something that they were not expecting, and they may need a bit of counseling to accept that diagnosis. So every patient is different, but the journey depends on the patient. But the basic things is, one, they need to understand the diagnosis, they understand what it entails, and know that diabetes is not the end of life. There are many athletes, there are many very famous people, there are many people who live with diabetes for a very long time. So just to understand that it is not a death sentence, and then how they are able to live, and tell them what they need to do in order to live a life that is basically normal. Yeah. So it takes a lot of time. Yeah, and that's why we take a lot of time with our patients.
I think a follow-up would be also now, for example, in terms of the treatment plans, what options are usually available for a patient who has been diagnosed with diabetes?
Okay.
So maybe you can just touch briefly on the
treatment
plan and options. Yeah.
So treatment of diabetes has come a long way from before, when at the beginning it was only insulin. Then we had oral medications, and the initial ones used to have a lot of side effects. And as time is going by, there are more and more medications that are being developed with fewer side effects, better management of the blood sugar, and the newer ones are even having other effects apart from managing the blood sugar, like helping with heart disease, with kidney disease, helping to even control the weight. So treatment varies, and the treatment is tailored according to the patient. But one thing that cuts all through, regardless of your age, any complications you have, is lifestyle management. And lifestyle, this is where your diet and exercise or activity comes in, and things like alcohol intake and such things. And you find with lifestyle, even if you do all these other things and you don't get the right lifestyle management, then chances of you achieving good care is much lower than someone who has good lifestyle management. And you get, once in a while, there are those people who, with good lifestyle management, they're even able to reduce their medication or even stop the medication. But that is with their lifestyle.
So when a patient presents to, let's say, your clinic, it's the first time they have high sugar levels, maybe you've diagnosed them and tell them now you're going to take insulin. I know some patients see insulin as death sentence, or I can't start injecting myself. So would you at least shed some light on that in terms of, if I'm prescribed for insulin, as in what would my life look like with insulin?
So the misconception we had with insulin, especially before, people would be prescribed for insulin at the tail end of their disease, when they already had the complications, either kidney disease or heart disease and all this. And because of the complications, some of these patients would end up dying. When people will get this misconception that once I get insulin, I am dying. And yet it is not the insulin. It is the disease progression. But with time, we are learning that introducing it earlier, depending on how high your sugars or your HbA1c is, helps you to control the sugars better. So the insulin talk is the one that you have to have with the patient. There are some patients who accept right away. Some of them you have to take them slowly over time, but just let them know insulin is not a death sentence. It's good just for managing your sugars. Just like any other drug.
Okay. And do they have to stay on insulin for long, or it's something that you start off with insulin, then now you go to oral drugs to manage their diabetes condition?
So it depends on the type of diabetes you have. Before we used to have insulin dependent and non-insulin dependent, but that has changed because now we call it type 1 and type 2, but this is a spectrum, and in between there are many other types of diabetes. So if you have type 1 diabetes, this basically means that you're not producing enough insulin. So for someone with type 1 diabetes, they'll need to use insulin throughout their life. But if you have type 2 diabetes, sometimes at diagnosis, your sugars may be too high, or your HbA1c, which is a measure that shows us how your sugar has been over a period of 3 months, may be high. So those are the patients that we may initially start on insulin. But for a patient with type 2 diabetes, with time, some of them you may end up weaning them off the insulin and taking them to oral medication. But it all depends on the patients, and all patients are different. So just because one person is using insulin forever does not mean the other one will.
Okay. And maybe also on now the insulin and the types of diabetes, I think I wanted to find out, is there a need for, because if you're going to change some patients, the insulin will be used and tapered off. How frequently would you want the patients to come and have a checkup with you?
Okay. So in the world of diabetes, we do not work alone. We work with especially people we call diabetes educators, and these are very important people. And these are the people who give the patients education with diabetes, because as much as I was saying we take time with our patients, we may not be able to cover everything. So a diabetes educator is someone who, once a patient is diagnosed with diabetes, will give them now comprehensive education over a period of time. It's not covered once, on their condition, what to expect, how to manage their condition. And one of the things they cover now is including insulin, how to take your insulin, when to take it, and all that. So usually how frequently we see the patient will depend on how well the patient is doing. So a patient who has a lot of information and is able to manage themselves well, and their sugars are well controlled, is someone we'll probably see less frequently than a patient who has complications, or we are not able to, they are still not achieving our targets. That's someone we now probably have to see a bit sooner. So even that is dependent on the patient.
That's interesting. So we also wanted to ask about diabetes remission. We've heard of the word diabetes remission. And some people take it, it's like you have been cured of diabetes. Maybe you can shed some light on this.
Okay. Diabetes remission. You remember I talked about HbA1c, which is a test we look to see how well your diabetes is controlled. And one of the definitions, there are many, but I think one of the main ones is when you have a HbA1c of less than 6.5 constantly, and you are off your medication. But the main thing to understand is diabetes remission happens in a patient who is very strict with their lifestyle, and this is mainly with their diet and also with exercise. And through this, they are able to reduce their blood sugar with just that, and they're able to get to a point where they can do without their medication and keep their HbA1c at that less than 6.5 or even less than 6. But the important thing to remember is diabetes never fully goes away, especially and before I say that, it does not apply to all patients. A patient with type 1 diabetes cannot go into remission. It is for a patient mainly with type 2 diabetes. And the important thing to remember is once you're stopping the medication, it is that lifestyle, it is that diet and that exercise that is managing your blood sugar. And the day you get tired or you stop doing those things, then your blood sugar goes back up and you require medication. And even as go time, you see there are people who are able to achieve that remission, but sustaining it for some people becomes a bit hard because it's a very strict diet and very strict exercise. So the important thing is it is not a cure. It is just a point where you're managing your diabetes with your lifestyle without requiring medication.